Good evening, everyone. Welcome to our Ergonauts Mission Control. And I know a lot of you have joined us before, and this is just another one of our series, Anatomy of an Injury series. Tonight, we'll be talking about risk factors for shoulder injuries, illnesses, and possible solutions. And just to start off for tonight, rules of engagement for our panelists and attendees. Biggest thing we harp on here is respect and dignity. We're gonna have an open discussion tonight, so just be respectful of each other. Other people will be asking questions, and we'll make sure to get those answered. And if you're an attendee, feel free to put any questions in the chat, and we'll get those answered by either Dr. Greg Pitts or any of the other attendees or any of the other panelists. I'm sorry. To start off with our intro with Dr. Greg Pitts. Again, he's done a lot of these for us, and we are very thankful to have him again tonight, and we feel very fortunate. We'll have him give his presentation, and then we will go over questions throughout the mission control tonight and at the end. And then we'll have Steve go over our sponsors at the end. And again, like I said, we have Dr. Greg Pitts with us. Again, we are honored to have you once again with us, Dr. Greg Pitts. And for those of you who haven't been to our other mission controls, Dr. Greg Pitts has over 3 decades of experience and has been a practitioner and an academic researcher. He's also a member of the board of directors for Hand Therapy Certification Commission, and he's also a member of the American Society of Hand Therapists. And he also has various clinics. So once again, we are very honored to have him here with us tonight. And Dr. Greg Pitts, without further ado, I will let you take the screen.
Oh, thank you very much, everyone. I really appreciate having the opportunity to speak tonight. A very exciting topic being shoulder and shoulder injuries. And there's no way we can cover the vast body of knowledge in 1 hour, but we'll go over a nice cursory of functional anatomy and injury and some ergonomic problems and solutions. So I'll share my screen, and then I will go into the mode and go to the anatomy screen here. And so this is obviously the lateral view of a shoulder and the bony landmarks as we go around the shoulder. We have the deltoid, the anterior deltoid, middle deltoid, posterior deltoid. We can spin the model around, and you can see the upper trapezium, the middle trapezium, the lower trapezium. They also, you can actually outline and see the scapula as it sits here in its medial border and comes up here like this, and the scapula. So this is kind of just to give you an idea. When you see it with the skin on, the front part of the shoulder, if you will, you can also, this area right here is an area where you can actually palpate the bicep tendon. So now as we go deeper into and explore the anatomy a little more, and take the skin off, and we go into, we can actually look at the same parts, if you will. We can look at the anterior deltoid, posterior deltoid, I'm sorry, the anterior, the lateral, and the posterior deltoid. The anterior deltoid flexes our arm. The lateral deltoid abducts our arm out away from our body, and the posterior deltoid moves our arm into extension. Now, things to think about with these muscles. These muscles I just outlined work in, they are temporal, or they move with conscious thought. They also move underneath motor patterns. So they move when we ask the arm to flex, it flexes. But the subconscious muscles that we worry about, that where most injuries are, you very seldom see a strained deltoid. You know, you can occasionally see a strained upper trap or a middle trap, even occasional low trap. But the primary muscles that you see hurt are the muscles that are subconscious in thought. Muscles subconscious in thought are the rotator cuff muscles. And these muscles can be injured very, very easily and they are the supraspinatus, the infraspinatus, the subscapularis. All these muscles work subconsciously, meaning that they actually work without thought, and they actually pull the humerus, the humeral head, into place. They actually pull the humeral head into place and approximate it into the labrum of the shoulder. And so they work without thought. When one gets hurt and you have a pain reflex occur, then it becomes conscious thought and the muscle loses function. It can be hurt from various reasons. We'll talk about that in a few moments. But the bottom line is to think about there are two types of muscles that we're dealing with, conscious and subconscious. And we'll put some muscles back on. And I'm at the rotator cuff level, subconscious level. Now, there are some more muscles that work subconsciously in the back, and we'll talk about. And these muscles are the serratus superior, the serratus anterior, which actually connect to the scapula here. Let me peel muscle back. So here's the scapula here, and this is the anterior wall of the scapula. And as I put muscles on, you can see the subscapularis, and that muscle actually, when it contracts, it holds the humerus in place, but it also helps hold the scapula in place. And we can add a few more muscles into here, and you can actually eventually see the serratus. These large muscles here actually grab a hold of the medial border here, the medial border of the scapula as it goes down. I'm drawing through the chest wall, but that's how it works. So when the serratus fires, it pulls the scapula close to the thoracic wall and keeps it from winging and keeps it stable. So when you're doing shoulder activities, reaching forward or reaching overhead, the scapula stays close to the thoracic wall, and it keeps you from having impingement syndrome, which is extremely detrimental to injured workers and people that get shoulder impingement. So what is shoulder impingement? It's probably the most common problem that we have in the world of shoulder injuries. And so what basically happens is that I can draw this out a little bit for you, but you can see the acromion, and the acromion is right here. And the acromion, if the scapula is sick, will come forward and impinge on, close the space on your rotator cuff muscles, particularly supraspinatus. And how does that happen? Well, the scapula gets sick. And so the scapula gets sick because these muscles that are deep subconsciously do not work. And so the lower trap sits here, and it does not fire. The rhomboids are sitting here. And then if I put a layer of muscles on top, you have the middle trap. So you got the lower trap, mid trap, and upper trap. So when you're doing shoulder activities, what should happen is the serratus should fire and pull the scapula close. Then the middle trap and the lower trap fire, which keeps the scapula close to the thoracic wall. If the upper trap fires, if the scapula gets sick and the upper trap fires here, the upper trap fires, it will allow the scapula to what we call protract or move forward. When that happens, that bony eminence that I showed, the acromion, will impinge upon the supraspinatus. And so when this muscle fires, the middle trap and low trap does not fire, and the serratus does not fire. Therefore, the scapula protracts or migrates upward and forward and impinges the shoulder. And so that's called scapular dyskinesis. Scapular dyskinesis. And again, if you look at it with the muscles gone, this acromion right here will rotate forward from the loss of muscle control, which is subconscious in nature, and it will impinge upon the supraspinatus. And that's called rotator cuff impingement, which could lead to rotator cuff tendonitis. It also can lead to bursitis, which is a really, really big problem in most industrial settings. You also can have rotator cuff tears from fall. You can fall an outstretched hand and actually tear your rotator cuff, particularly in your 50s and 60s. You can tear your rotator cuff. You also can tear a structure which we call the labrum, and the labrum is a the joint of the shoulder itself. And we can zoom in here on this and look at this closely. But the labrum, I can put some connective tissue in here, and that's going to show the shoulder joint. And basically, this is the bicep tendon as it goes into the shoulder itself. You can see the shoulder capsule here. You can see some bursa. And then when I strip away connective tissue, you're going to see the bone. And so this is the head of the humerus, right here, the head of the humerus. And it seats onto a really, really small area on the scapula called the glenohumeral joint. It's very, very small. It's held together by a fibrous structure that kind of acts like a suction cup all the way around the bone. It's called the labrum. And when you have a labrum tear, that's where the joint capsule's been injured. And this can be a really, really big injury because now you've got a major injury and tear that actually makes or allows the weight of the humerus to drag down from gravity and actually pulls the supraspinatus and pulls all the rotator cuff muscles. They activate, and they can't activate all the time. So then you get muscle pain, you have joint pain, you got a problem. So how does labral tears occur? It could be from a sudden jerk, from a heavy jerk, a heavy weight falling on your arm, or you catch it, or you're doing a lot of heavy work and a quick torque can cause this problem. But this is a very serious injury and takes quite a while to recover. Oftentimes they'll need surgical repair. Also, a full thickness rotator cuff will need repair. But before they do any of it, most good surgeons, shoulder surgeons, will have the worker go through a series of scapular stabilization exercises that will actually help them prepare for surgery. And oftentimes with a small rotator cuff tear, or what we call bursitis, we can do therapy for them and actually make them feel better and stop the impingement. What do we do in therapy? Well, we do modalities and soft tissue massage to get the upper trap to calm down. We do strengthening exercises to strengthen the rhomboids and the middle trap, rhomboids and middle trap. And we also do activities to strengthen the lower trap. And by doing that, and then the one exercise what we would do is we would also do pec stretches. We'd stretch the pecs out because the pecs will get short. The pectoralis minor will get short. So we stretch out the pecs, and then we also strengthen the interosseous muscle, the serratus muscle. So the serratus is strengthened, the pec is stretched, the trapezius, the upper trap is relaxed, the middle trap is strengthened, rhomboids are strengthened, low trap is strengthened. That will pull this shoulder back into retraction and will stop the acromion from impinging upon the supraspinatus. And that really is the gist of, or the basic premise behind what we do in scapular retraining. Now, if your scapula is sick and you're doing forward reach activities or overhead activities, that scapula is going to not act like it should. It's not going to go into retraction and stabilize. It's going to go into protraction and impinge. And so you can see why, oftentimes these muscles, these core muscles, these subconscious muscles become fatigued through activity. And so again, they are subconscious, but over time, if you're doing a lot of work, 8-hour, 10-hour day, these muscles can become deconditioned. Also, if you become older, as you become older, and the shape of your back actually changes and goes into a kyphotic state of shape, if you will, it also will promote a problem. Kyphosis will promote a protracted position, which is something we face with the aging population. So as we move forward, there's one more area I want to talk about, and then we'll move into some other slides that we can actually get some discussion going with. And that is, let me take some muscle off. And that is, I'm going to talk about brachial plexus injuries, nerve injuries, which are also very common. and they're becoming more and more, people become more and more aware of them. But the brachial plexus is the nervous system that actually supplies the primary mover activity for our upper arm, bicep and tricep, and our lower arm being our digits, our forearm, pronation, supination, distal flexion, extension, wrist flexion, extension. And these nerves can become irritated. Oftentimes you can have carpal tunnel symptom syndrome, carpal tunnel symptoms, as well as cubital tunnel ulnar symptoms. And actually the lesion can be in your neck. And so the three areas of compression site that we screen the most often is the scalenes here. The clavicle and first rib is the second side of compression. And the third side of compression is the pectoralis minor. Again, these symptoms can create numbness and tingling in your hand. They can create, if they impinge the muscocutaneous nerve, it can create bicep weakness. C7 can create tricep weakness. We can have radial nerve irritation. There's different things that can occur, but oftentimes they can have a lesion up in their neck at the scalenes, clavicle, first rib, and pec minor. So things to consider. I'll stop and answer questions now, and then we'll move on to a little bit more pathology, and then we'll go into ergonomics and risk factors. Any questions?
Yeah, I raised my hand. I would like officially, so.
Okay, I'm sorry, but I couldn't see. I can't see anything.
I'm just kidding. No, I did raise my hand, but so Greg, let me ask you something. You've been on site, and I don't want to get the cart before the horse here. When somebody walks into your clinic, you've been on site Toyota for years. You had a clinic. If the injuries that we're talking about, what are they going to tell you when they walk in? What's going to be the symptoms? I'm not talking about any treatment or anything like that, but so, and the reason I ask, I actually have multiple injuries, but I have one in my neck, and I could tell when you mentioned a clavicle. When my son was young, I would ride him around on my shoulders, and I probably get about 20 pounds too long. But his legs would cut into my clavicle, and my hands would go numb almost instantaneously. So I'm just curious.
Well, they're going to have the symptoms of the brachial plexus. You're going to have numbness and tingling in your hand and forearm,
right?
Maybe in your upper arm, because in that situation, your son's sitting on your shoulders, it's dragging down on the shoulder, compressing the clavicle, the first rib, and compressing the nerves there. You're also going to have shoulder pain if you compress C5. You can have shoulder pain and on top of your shoulder. A rotator cuff are going to have pain with motion, and labral tears will have pain at night when they sleep. If they sleep on their arm, they'll complain of a lot of pain at night when they sleep. And they'll usually have an injury that's going to correlate with the problem. So they're going to have a problem with movement, but they're going to be able to tell you it hurts when they carry something heavy. That it's going to be a problem when they try to sleep at night. It's a labral tear. When you have a tendonitis problem, they're going to have problems when they move. It hurts when I put my arm forward. I try to reach forward, it hurts. I try to reach the side, or try to reach behind me, and it hurts. So it's more of a motion. It's pain with motion is your tendonitis problems, whereas your labral tear is pain at night when you sleep, and usually have an incident that occurred. Brachial plexus is going to have numbness and tingling involved with it downstream.
Yeah,
now that help.
Yeah, it did. That's like I say, I've had a neck injury for years, but I can tell, when it's active. Half the things that you talked about so far, I've experienced with my neck back. So this is a great subject. I was just curious about that. Sorry, go ahead.
It's a very common thing, particularly males over the age of 50. They have a lot of shoulder injury or shoulder problems, and they'll have partial rotator cuff tears. Would be very, very common in males, and they can be in office workers. They can be in people that play backyard football. They can be, it doesn't really matter. We're going to have wear and tear on our bodies. It's going to show up in the form of some type of rotator cuff irritation. Larger injuries like from heavy jackhammering or heavy lifting or stopping something, the labrum can slowly become torn. Remember, I showed you the bicep and how the bicep enters through and into the area. This is the bicep right here, the bicep tendon. The bicep is actually part of the labrum. So if you're doing really heavy lifting, you can actually get a labral lesion or tear from heavy lifting because the bicep is actually part of the labrum itself. And so that'd be a good segue to move into. Yes, ma'am.
Yeah. So can I? One of the things that I've noted in my many years of occupational safety and health is we get these women in and they're working, and unfortunately they have a piece of freight that is too heavy for their upper body, and it not only pulls their shoulder and we end up with a rotator cuff tear, but it also will herniate a cervical disc, and it complicates the diagnosis.
Oh yes, it could, because then you have to do one telling sign that you can do to determine between a C-spine injury and a shoulder injury. If you put your arm overhead, the pain will go away if it's a C-spine, because it actually shortens the nerve root at the level of the C-spine itself, so it takes pressure off the nerve root. Where if it's a brachial plexus injury or a shoulder injury, if it's brachial plexus, the numbness and tingling will go up, or pain will go up. Or if it's a shoulder injury, the pain will go up. And so that's a nice little trick to use, is to ask them to raise their arm to tell. Sometimes you can have both, and both need to be treated. Go ahead. I'm sorry.
Yeah, both need to be treated. Another thing that we always get when they come into a clinic is the person will say, "I'm having burning," and they reach back, and it's the upper scapular area where they're just having burning, and you're going, well, let's put some biofreeze on that and send you back to work. But after all is said and done, when we get through this, we'll talk about like modified duty after we have them see a physician and get them triaged out. So I'll stop those comments now. Thank you.
And I think it's good. You're burning. This is an MRI. It's a labeled MRI, but you can see the trapezius right here, and the upper trap. Because it's co-contracting so much, trying to compensate, the muscle has stored waste products, and that's where your burning comes from. It has a burning sensation from the stored waste products off, and they'll have a lot of heavy co-contraction trying to control the scapula, trying to take stress off the nerve root from a C-spine injury, and you'll have that burning pain that comes from the trapezius itself. That will be a problem for you. I'm showing this MRI just as to show you kind of what it looks like in real life, and you can easily see how if you have a forward, if you have a scapula, here's a scapula down here, this ridge of the scapula that kind of sits like this, then realize that this acromion is actually part of the scapula. Here it comes out and protrudes. So when the scapula is sick and it protracts forward, you can see how it would impinge on the supraspinatus muscle and cause a problem. Very, very easy. You can see the interval of a normal rotator cuff is actually relatively small as it lays next to the humeral head. It's a very flat and thin avascular tendon. So when it gets worn a lot from activity, if it's not taken care of, and if it has any impingement from the acromion as it comes down, you've got a problem. Also realize the fact that there are 3 types of acromions, and some predispose workers for injury because of their shape. They can be extra big or extra long, and so it doesn't take much protraction or scapular dyskinesia to actually cause an impingement. So oftentimes you'll hear what they call an acromioplasty, and that means they'll actually go in and cut off part of the bone of the acromion to give the tendon more space. So moving on, I've got some pictures here you can actually see. And what do you see here in picture 1? We'll go picture 1 here. Here's picture one. What do you guys see here? Anybody? We can
They
see.
don't look the same. The scapular areas are not the same.
Yeah. So
And
you
the
can see the
traps on each
shoulders are the
side.
same. The
Yeah.
arms
Yeah.
are the same. There's the same posture. But see how he's firing his upper trap is really firing really hard, which is pulling his scapula forward, which is going to cause impingement. So if his scapula, if he's sitting like this in this posture, he tries to raise his arm up, he's going to have impingement at his shoulder level. So the forward tilting of the scapula with trap fires creates protraction, which closes the interval for the rotator cuff, which causes impingement. Also, you can see here this gentleman here has winging, which tells you they have a very sick serratus anterior. So it could either be a long thoracic nerve, or it could be a serratus that's sick, a scapular dyskinesia. You can see here another one. You can see how the gentleman is trying to raise his arm up, and so you see the winging that occurs here in the scapula. Here he's doing a lot. He's even doing some trunk lengthening as well as firing the trap to try to raise his arm up, and not being very successful with it. So posture and being able to evaluate posture is extremely powerful. Looking at the side at the worker as well as the back at the worker, watching how the arm moves, and we evaluate this and identify this with almost every upper extremity injury. It can be an elbow fracture, a lateral condylitis, medial condylitis, TFCC tears, carpal tunnel syndrome, cubital tunnel. They all have this scapular sickness that occurs. That's very, very common. And so we it's part of our treatment program when we see people for injuries, distal radius fractures, all these have problems. So what happens is what should happen is that the serratus anterior should fire and pull a medial scapula close to the thoracic wall. The upper trap should somewhat relax, and the lower trap pulls, which actually keeps the scapula close to the thoracic wall and stops the impingement as the shoulder rotates up overhead. And what happens is the workers get tired. Subconsciously, these muscles are supposed to work all subconsciously without thought. They get tired, they get sore, they have back kyphosis, whatever, and they may have a small thoracic back strain from a heavy lift or a C-spine strain from an activity or turning or driving a fork truck, whatever, and it changes this scapular rhythm that can occur and cause the impingement in the shoulder. So it's a very tied in system that all depend upon each other. They're very interdependent. So here you can see as your arm goes overhead that the mid trap has to fire, the low trap has to fire to keep the acromion away from the humerus and away from the supraspinatus. So it's very, very important. Again, when low trap fires, it pulls the scapula down, and the serratus pulls the scapula close to the thoracic wall and keeps the acromion away from the humeral head and the supraspinatus. When it doesn't work and you have impingement and you have protraction, this is the front, if you will. It's the coracobrachial process. This is the acromion, and you can see the impingement that's occurring at the supraspinatus and at the bursa that sits right above the supraspinatus, causing a phenomenon called, here's the acromion again, here's the supraspinatus, here's the bursa. It can cause bursitis or rotator cuff impingement. Pain, discomfort eventually could cause a rotator cuff tear. And this is the final shot where you actually see the bursa inflamed, the muscle sitting underneath the bursa, and the acromion impinging on it, which can occur over time. This is a repetitive motion injury, because it occurs every time the person lifts forward or overhead. It's going to make that scapula, if the stabilizers are weak, which they often are, then you're going to see this is a very common problem. This is not uncommon. It's one of the most common problems we see with shoulder injuries. And they are also symptomatic from other upper extremity injuries. I'll stop here and answer questions before we move on to the labrum. Any questions?
Yeah, what's the purpose of the bursa?
The bursa is a structure that will actually create cushion between structures. It also can add some element of nutrition for the muscle. So it's like having a insole on your shoe.
So you're saying that reaching forward, the risk factors for that are it's repetitive motion and it's also posture. And you reach forward repetitively. Is that, I don't know, am I asking the right question?
No, you're asking the right question. That's fine. If you reach forward over and over again, and that scapula, the scapula is indirectly connected to the shoulder via the labrum. And that scapula doesn't have good rhythm, and it has a protracted posture every time you do it. You're going to impinge and bang on that supraspinatus every time you reach forward. Whereas if the muscles are working correctly, they're going to pull the scapula back the other way and allow room here for the shoulder to clear as it rotates up and lifts. This bone rotates this way when you lift your arm up. And so if the right muscles work, it will allow clearance as you raise your arm forward or overhead. If it's not, and the scapula sits protracted, it will create repetitive motion and eventually tears to the bursa as well as to the supraspinatus.
Hi, this is a question about the epidemiology of this. You're talking about it's a function of the repetition and the force. What does the medical literature tell us about the duration of repetition, the how many repetitions per hour are we that become of a concern?
We don't know. Not to be a I wish we did know. I could make a whole lot of money if I could predict what it is, but you got all these different things playing the factor: the type of job, the level of reach, the anthropometrics of the human, the age of the human, the physical condition of the human. All those things play a role, because if the person's in really good condition, and they're young and they've got really good core stability, they can do a lot of work at shoulder level, overhead level. Just go out the chassis line sometime and look. You'll have nobody over 30 out there in chassis line. They can't do it. They won't survive contact. They can't survive the repetition of 500 reps overhead every day. They can't do it. And it's a young man's sport. So what I'm trying to say is that there's no good dose relationship to dose, force, repetition, and injury. We just know that it occurs because this system gets sick and doesn't work right. And like I said, it's trying to say that the kyphosis in the back is a result of the age. Physical condition is going to control the body and they control the core. Some people are motor morons. They don't have good motor control of their body. And those people do not fare well in a very active work environment. They don't do well because they've never worked before. And so we got people that are trying to go into work and production that have been sitting on the couch and watching Captain Kangaroo, and then they try to go to a factory and work. It's very difficult. So, the solution is to try to engineer these reach envelopes out and this overhead reach out to try to avoid the scapular protraction that occurs. And now I'll get into that in just a few moments as we move forward. But I wish I had a dose relationship. I don't. Maybe somebody else on the panel has read something or seen it, but I have not seen it. Labrum. The best way I can describe a labrum, the labrum here being the cup where the humeral head sits, is like a golf tee, and the humeral head is like a huge like a basketball. And so that the surface area of most joints and most joints in the body are driven by the contact area of the joint. In this situation, the shoulder and the labrum is driven by the labral as it attaches like a suction cup to the humerus as it sits into this small cup. It's also driven by the large number of muscles that actually hold the humeral head in place, the rotator cuff. And it's those muscles are very, very important to keep that shoulder in place. If it doesn't and it pulls out, and the rotator cuff doesn't work, it puts more stress on ligaments and changes the kinematic movement of the humeral head itself, which can cause impingement as well. If the humeral head is not pulled in place as it's rotating up overhead, the greater tuberosity can actually impinge on the acromion, and that's a different problem. Labral creates a different kinematic movement of the humeral head, which causes impingement because the greater tuberosity cannot rotate away from it as it goes into overhead extension. And you can see some small areas where you have this is a labrum tear called a slap lesion, which is a superior labral tear that comes off the bicep tendon. You can see the labrum itself, the glenohumeral joint. You can see it's very, very small and not very strong. Here's another picture of all the different muscles as they wrap around the humerus, and the humerus sits right in this socket, if you will. And the labrum is like a cup, a fibrous cup that holds the humerus in place. Here you can see arthroscopic surgery where you can actually see the labrum is torn. You can see all these little fibers here are all part of the labrum that's been torn, and the surgeons will go in and actually see that here. Let's see they're pulling up. See, this is all the labrum. We're pulling it up away from this is the glenoid, and this is the humerus itself. So it actually you can see that it can become very frayed and a big problem, and that also causes some internal joint impingement. So you can have different types of lesions. You'll hear about these a lot. You have a slap lesion, and they'll say it's from 10 o'clock to 2 o'clock, and a Bankart lesion is from 3 o'clock to 6 o'clock. These are two basic types of labrum tears that occur in the shoulder. This is oftentimes from heavy lifting and forward reach, and this is oftentimes from overhead activity. And the reason why it's overhead activity, Bankart is because when you put your arm up overhead, the humeral head has to glide into this capsule this way. It glides this way as your arm goes this way. So it puts a lot of stress on the inferior portion of the labrum. Questions about the labrum? Then we'll go to brachial plexus, then we'll go to ergonomics.
Greg, is the labrum something that is particularly vulnerable as we age as well?
Yes, it becomes fibrotic, or it becomes what we call avascular. So ligamentous structures as we age become brittle or become avascular. They're already avascular. So the ligamentous structures are they're stronger than bone. But as they age, they can't take the same torque and the same motion. And so they start cracking and fraying and tearing. And that's what happens with age. People that have good genetics, they don't tear as quick, but most people are going to start seeing changes in ligamentous structures in their 4th and 5th decade of life. And then here we got an aging workforce. So we're going to be seeing a lot more of these I can accurately predict that we'll see more as the force ages in the next 10 to 15 years. A ton of shoulder injuries, ton of knee, back, all these problems occur from aging and from changes in blood flow. Last but not least, we've already talked about the brachial plexus, and we mentioned on C-spine. And so I mentioned earlier that if you raise your arm up overhead, it actually will make these nerves, nervous tissue kind of go this way and take pressure off the nerve roots. So if you raise your arm up overhead and pain goes down, then you may have a C-spine issue. But most of the time, when you raise your arm up or forward, it puts a tremendous amount of stress on your brachial plexus and your muscles. Think about this. If you've got a lever arm here, and I was going to talk about this in the pictures, but you've got a lever arm and you reach out. If this weighs 10 pounds and your arm is 30 inches long, mine's 37, by the way, 30 inches long from the shoulder to the force couple of your hand, then you're going to have 300 pounds on your rotator cuff, 300 inch pounds on your rotator cuff. So this structure takes a lot of force throughout the day. When you raise your arm overhead activity puts 5 times more pressure on the brachial plexus than when the arm is below. So if you already have a nerve injury or nerve issue and you're working at above shoulder level, you're asking for 5 times more force on this brachial plexus. These are not uncommon injuries, particularly as we age. If you lift something heavy or catch something as it's falling with an eccentric load and you get this pull down, you can injure the nerves and have a pretty big injury. We've got a worker right now. So this is a tire blew up in his face, and it actually tore. It actually has a huge brachial plexus lesion. It broke the collarbone, and it broke C5 and C4, and he had a severe brachial plexus injury. Tremendous. And one of these big tractor tires blew up in his face. So ergonomics and risk factors. We see a lot of them every day. How do we talk about them? How do we quantify them? There are several tools out there. I'm very familiar with the Reba and the Rula, but I'm just going to go through some basic stuff today and talk about risk factors. There are all kinds of risk factors: awkward postures, static postures, forceful exertions, repetitive motion, vibration, context stress, and environmental factors. But one of the things you think about when a reach envelope is in neutral, it goes from the center of gravity of the shoulder to the coupling pattern of the hand. And therefore, this is what I would call it's still a large reach envelope, but it's a neutral reach envelope. When your reach envelope changes and you have to change your trunk to accommodate the reach, now you've got 2 problems. You've got a low back problem, you got a shoulder problem, and people are going to accommodate. Oftentimes there'll be a structure here in place, but a lot more force is going on the back. Now when you start lifting here and you've got 10 pounds, you got the length of your arm and the length of your back, put it on L5S1 as well as your rotator cuff. So you got to think about these things in the compounding impact. Neutral versus max reach envelope. So here now, look where your neutral is. Your neutral is the length of your forearm. And that changes with the size of the human. But the length of the forearm is what you would call a neutral zone or the ideal zone for reach, particularly either seated or standing. Obviously, the top view as you reach forward. As you move back, maximum reach with light activities can be the length of your arm. That does not change your body rotation. If it changes your body rotation, you've got a problem. And then extended reach, you actually change your back. So this is a back change. This is back and shoulder. This is shoulder. And then this is the safest area here in the neutral zone, if you will. So we're always shooting for the neutral zone. There are several things published on this to help you, but good old common sense in a picture can go a long way with helping you determine if it's a good reach or not. So we can look at some of these pictures and see, but we can see here we've got a gentleman working overhead here, working up here on an object, and so we got awkward postures. We probably have static postures. I can't see the force, how much force he's working with, but I venture to say they're doing some repetitive motion, doing it all day long. I'm pretty sure he has a power tool, vibration. So we're already getting into quite a few risk factors just by looking at one picture. Now let's get down. Now we've got a lift assist that's occurring. The shoulders are down below shoulder level. The hand is above shoulder level, but his arm is below shoulder level. He's got a lift assist. So now we don't have awkward postures. We have a sustained posture, but it's relatively safe. I venture to say there's not forceful exertion there. There may be repetitive motion. I don't see and don't suspect vibration, and I don't suspect contact stress. So we got a decent job here being ergonomically correct, putting a windshield into a car. Now, what do you see here, group? We'll go through this together now. What do you see? Is this good, bad, poor? What do y'all think?
I'd say that looks fairly neutral.
I think it looks, I agree, it looks pretty good. So I always draw an imaginary stick figure in a picture when I look at it. I think there may be a little bit of low back, but not a lot. You got your arm down to your side. You come in here neutral. Pretty easy to see. I love to take and draw on pictures and just kind of think about what I'm seeing from a point of contact. So he really does not have a large arc of reach envelope. He's got nice big long arms, a big dude, but I don't see a lot of awkward posture. I don't see that. Sustained posture, maybe. Forceful exertion. I don't know that answer right now. It may be repetitive motion. I don't see a hand tool. I can't tell what he's touching, if there's any contact stress or not. That's a question mark. But it's just think about, what you're seeing.
Yeah.
Here, let's go to the next one. What we got here? What do y'all see?
Awkward posture. I'd say that one for sure.
Which one?
The guy that's underneath this, the guy to the right.
Underneath. So now we got this here and here. So we got trunk rotation. We got overhead activity. See, look at his head and his neck. Right there's his head and neck. He's over. So he's got neck posture problem, back twist, torque problem. He's got overhead activities. What's the gentleman over here on the left have?
He's got, a little bit overhead, but
he does have overhead. He's close to the work. His work's close to him. He's still got a pretty large reach envelope. So he's got an awkward posture. Could be a static posture doing the activity for a period of time. I can't tell about the force, but I'm sure they're doing this a lot every day. So you gotta get the idea as we look through these pictures, what you're seeing. And here's a good shot. What do you see here of the guy on the left? Anybody?
he's
What's the posture like?
It's a really long reach there.
Super long reach, right?
He's leaning forward too to get to it.
He has to lean forward, right, to get to the reach. Yep. Good eye. Good eye. Good eye. Now, what about his neck's in relatively neutral posture? That's a good point. Now, what do you see this gentleman over here to the other side, the one on the right?
It's pretty neutral.
Yeah, he looks pretty good.
Except I'd be concerned about the static hold he may have to do to keep his arm in that position for a long period of time.
This guy here?
Yeah, I don't know exactly how the job works, but it looks like he may have to maintain that posture to run that process.
Well, you may have to. You're right. So, and that would take a little more investigation. So, at first glance, it may look good, but we may have to look harder. But being able to identify the postures is really extremely valuable as a first step. Here we got a 2-man lift assist, putting in a rear window. So we see with this ergonomic design, they didn't just design the lift to hold the mirror. They actually kept the shoulders down, neutral posture. See how close their arms are to their body? They can get close to it. They're staying within that nice reach envelope there. So they really have done a lot to take the stress off putting windows in. I can remember the day when this was done, not with the lift assist, and it was quite stressful on the human body. So the cost of this animal may be in the hundreds of thousands, but it really saves backs and shoulders. Okay, what do you see here? This is kind of crazy. What do you see here? Well, let's look at this guy right here first. What do you see there?
He's reaching forward, bending forward, and he has to tilt his head back.
Yep. He's also twisting his torso. Look at his feet versus his torso.
Yeah.
He's got a twist, larger. It's almost excessively. I don't know how he's doing the job, really. I mean, I don't say how he sees the process. This looks like this table's blocking him, but he's got a twist in his trunk. I don't know how good his feet are. He's got a lean forward, large reach. He's got a lot of things here to fix. Oh, here we go. Now we're getting into some fun stuff here. Now what do you got? Let's talk about this guy on the left first. What do you see here?
Oh, he's just leaning over. Good heavens. That's a
pretty good size L factor. So his arms are actually forward, but really a really heavy stress on his back. Look at this guy over here. Woo! Look at his neck posture. Back.
My back hurts just looking at him.
Now, man, imagine doing that all day long, and they wonder why people complain of pain. I don't have any hard time figuring that out. Oh, here we go. This is a truck. I don't know what plant this is in. All these pictures came off the internet, so I'm not how do you say, showing any pictures from any particular plant or car manufacturer. But look at this. Look at the 1 foot on the ground. Really?
Wow.
Trunk. Is that
Gotta work
crazy?
out.
C-spine torsion, shoulder posture, maybe
Or
sharp edges, repetitive. So we have awkward posture, static postures, repetitive motion, contact stress. Wow. That's a definitely interesting one to examine, right? Now here we go. Now we got another machine assist activity. What do you see here with this gentleman?
pretty good posture. He's reaching a little bit, but pretty straight up for
Yeah, not too bad. I'd say he's probably in that second zone reach. He's got a assist helping him with the activity, but it seems like he's doing okay.
And his feet
Whoa, here we
are
go.
at a stable base.
I'm sorry.
Looks like he has a stable base. His feet are more like hip width
Oh,
apart,
yeah.
or so, not having any balance issues with the machine.
Perfect. Eye. It's a good eye. That's right. He's got, so the machine must have pretty good balance. He has good feeding. He has good technique. What do you see here, guys?
Well,
slide
it
this
looks
guy
like
in.
they've tried to engineer a seat for him to slide back in there on. I mean, so they've made an attempt at engineering, but I guess the air hose wrapped around his leg is somewhat
Air hose
unergonomic.
may be a problem there. You're right there. That's a good eye, Steve.
Yeah.
It should be,
Mhm.
this probably should be counterbalanced. The tool should
Right.
be. They did build a seat here that kind of supports his back, and I don't see any support for his neck. So his neck is in trouble, and he's having to use quite a bit of acuity to get this power tool up in here to shoot a tool. But it's probably better than what they were doing climbing into the car. They have a
Right.
lot of contact stress on their knees, their back. So they're trying to make a change. They're trying to make it better. And I'm sure this device goes in and out throughout each process. But I wouldn't want to ride this bull all day.
And I bet if he was there for 2 months before they implemented that change, I bet he's real grateful for that, to be honest with you.
Oh, you're right. You're right. When one has one has nothing, little is a lot. And this is probably a decent fix. If he rotates out of this, every 2 hours or so, he's probably going to be okay.
That's
But
right.
it's still better than what it was, but it is still a tough job. And sometimes we can't fix everything. Here's a shot of an exoskeleton at this point, and they're trying to really fix overhead postures. And I've talked to employees that wear these, and they're very happy with them. They say it really helps them with fatigue throughout the day. They say though, if they're not working, it can be a pain, but most of the time they do a pretty good job for them. So I've heard pretty good feedback. Has anybody else heard anything else about the Exos? And I know we had a class on it earlier, but does anybody get to see these, practice?
In prepping for this, I pulled some of the recent literature, and there was a very interesting study from Virginia Tech that took place over 18 months with this same setup, actually, and they found that it made people feel more comfortable, but the comfort level really determined whether they want to continue to use this device or not. There was a break. If it were more than on a scale from 1 to 10, 0 to 10, greater than 6.5, then it would change their perception of how they would continue to use the device or not. And then there are other studies that have shown that it can reduce the peak muscle force, and people do report feeling less fatigue, and that type of thing. So that they have some good feedback from those things. But it really seems to depend on the design of the particular exoskeleton. And in fact, during this 18-month period of this one study, afterwards, the manufacturer stopped making that particular model. So the research is behind for what may be current.
I think we need to see some studies where they actually do EMG hookups of different muscles,
Yeah, they have
particularly
done
if
some
they.
with overhead drilling work at Tech as well, and they found that it changed speed and can have some issues with the quality of overhead drilling with those.
But I'm saying muscle activity and muscle fatigue, we could easily study that with EMG activity and see with and without and see how much activity is there. And maybe
Yeah,
it's already been done, but that'd be an
it
interesting
has
study.
for some things, but what
Okay.
they're also discovering is that when they're in a sense replicating these studies in actual manufacturing, like we've been looking at tonight, the efficacy of the exoskeleton seems to decline from what we learned in the laboratory controlled studies. They
I
not
see.
may not be doing as much as we think.
I see.
There's some caution there.
Interesting.
Yeah.
I've just heard people. I've just had feedback from people. I don't know. I've seen them a lot, but I don't. I'm not get to study them a lot. So I think it's fascinating. I hope hopefully in the future we'll get better at this to give more and more solutions for prevention of injury.
Greg, I'll tell you
Wow, what do you
something
see here?
interesting. We've got Atomic Ergo, the podcast, and out of the last 6 people, 2 of the top people in safety and health on the planet were interviewed. And there's at one point, you kind of talk about what you pick your topic that you want to make a point, and 2 out of 6 actually picked exos as being the challenge and probably the solution. But the problem that they both recognize is there's not a lot of widespread education out there. It's typically within the exo industry, and they're selling it to each other instead of training a workforce that understands how to go out and look for what does that look like if I see the problem. So, is that a potential solution? Because people don't understand so that's, but I think, and the other thing is the aging workforce. You reference the aging workforce, and man, this is going to be, and the other thing is, if we really did have a recession where we laid some people off, the way the seniority system works is the oldest, longest tenured employees get to stay with the company to keep their salary going. But they may be going back to a job that they've not done in 20 years. They've moved.
You're right.
And so you've got somebody that's, potentially done sedentary type work, and then they get thrown back into a 20-year-old, a job for a 20-year-old. And it's like, oh, wow. So, I don't want to talk about the perfect storm, but if that did happen, that greatly, you're going to see a lot more, because you saw it back in the recession of 2009. There was an increase in, injuries due to poor ergonomics, but it was exacerbated by age. So anyway.
Good points. Very good point. Let's see what happens as we move forward. Here's another shot. What do y'all see here? Wow, I see environmental. No, poor lighting.
Stress.
Wow. Well, you got the wrong tool. You got the wrong line. Should be coming from the top, not the bottom. You got this tool is designed for what? What surface? It's a pistol.
It's vertical. It's designed. Yeah.
It should be vertical. It should be a vertical surface. And he should have an inline tool, a straight inline tool for this job.
Right.
And then that's just the tool part and the lighting part. Now we get into the human body part. What do you see?
Well, I think the person's using the non-dominant hand because of the watch on the right side. So the person's probably left-handed and using the right arm then it's not the dominant one.
Good point.
Yeah. Toyota would argue with that and say you're supposed to be able to use both arms equally. That would be that's one of their little pet peeves, is they make people learn both arms. But that's a side point. So what do you see in the shoulder? What do you see in the neck here?
It's bent and twisted. I just see
It's
pain.
twisted, yep. Makes me hurt looking at it. Extreme posture of the elbow.
Hmm.
A lot of stress on the shoulder. Look at the awkward posture of the wrist. We
Yeah.
just got all kinds of cool things going on here. A lot of problems. And then they wonder why somebody's got a hurt wrist, back, knee. I'm sorry, wrist, back, neck, elbow.
So these are really
Well, now we got all kinds of
nasty.
people working on one car.
These are really nasty pictures here, Greg, you
They're
know?
typical though.
When I look at this, though, I know we used to do job analyses to determine what we could do to make the job easier for the employee to do. Any good company worth their weight has job analysis and works to make it an ergonomically safe job. You know, I guess I look in terms of the best world, you know. So yeah. Whew.
I can tell you that my experience has been the smaller the company, if it's small, they want you to identify ID problem and ID or make ready for solutions. Larger companies that have ergonomic teams and engineers, they want you to help identify and quantify the human factor and the human cost.
Right.
And so that's my job is to identify the human factor problem and why. And then the engineers design it out. I'll give them recommendations on the design, but they actually design out, the engineers do. So, but that's been my experience. The bigger the company, the more people helping. I'm just a small piece in the cog, whereas the smaller companies, they need a lot more help with this because they don't have big engineering groups to help them. Oh, we got here, guys. I mean, I switched gears a little bit and I went down to the wrist and hand. So, you know, you're going to have obviously vibration, maybe or maybe not some contact problem. What else? Cup pattern could be loose because a lot of grease here, be hard to hold. So forceful exertions,
And you're going to
postures.
And you're going to have all those wrist problems you talked about in one of your previous mission control.
Yep, you're right. Compression of the ulnar wrist, stretch on the radial wrist. Some bad stuff here. Oh, here we go. There's the ultimate. Where do you start with that one, guys?
Yeah.
Have you ever watched these guys work these floaters? These are called floaters, concrete floaters. They're amazing. You talk about hard work, man. They work hard.
Oh, they do.
They are tough people. He's got all his weight on one leg, extreme back posture, forward shoulder posture. You know, has to have balance, poor footing, only one foot's in, pushing a real heavy, large reach envelope, pushing it back forth across that concrete. I've watched these guys do this for hours. It's back breaking. Here's another floater in the background standing here floating that concrete. Unbelievable. So you got all kinds of stuff going on here. You just keep on going here. Here we go. Side, overhead, neck. It's getting repetitive now. Here's a portable jackhammer. I've only seen these one time, so I've seen the bigger ones, but not these smaller ones to knock walls down. But has to have a lot of heavy co-contraction, the shoulder, the back, the neck's in a bad posture, the back's kind of crooked. This is, I'm sure, a very heavy machine. It's fed from the bottom, not from the top. It's got to be very heavy. He's holding the hose and the tool itself. So he's working. This guy's not a how do you say, a lightweight, pretty strong dude. I'm sure he's still extremely stressed. And you got your typical jackhammer. And if you don't ride these puppies right, there's an art to doing these. And I've rode several of these at my time. These can actually, they can beat you up like a demon. And anybody in the phone calls not use a jackhammer? They are killers. And they look easy, but they're really tough to use, and they'll beat your brains out if you don't use them right. So now we go back to our first starting point, and what do we see wrong? Large back, large shoulders, possibly heavy activity, unsafe basis. So we'd have some fun with the cartoon at the end. This actually concludes. I'm gonna break from this and go back to the panel. And just answer questions. Hello?
Hello.
Yep, we're listening.
Somewhere I can't see you.
We're
There
here.
you go. I missed you. Sorry
We're
about
here.
that. I'm good.
Awesome. That was great. We'll open it
So,
to a panelist
any
for
any questions, guys?
I am just so impressed. You're an awesome teacher with those muscles. I mean, I love listening to you because you get into the detail where I'm going, oh yeah, the deltoid, you know, it's not this side, this side, this, you know, I just don't do that anymore. But how you pull together that information and use the slides and the 3D to show it. It's just awesome, Greg. One of the things that we've always talked about is you put an injured worker back into the same job that put them out of work to begin with. Means you're going to have the same kind of injuries coming down the road because you haven't taken care of changing the job up. So how often do you get to go in and change some of those jobs? Now I know Steve has done it, you know, because that's what ergonauts do, is they change the job so that the human doesn't get hurt anymore.
Yeah. Well, you're asking how often I get to do that. I used to do it a lot. I'm tied or tethered now to the company so much that I'm treating so much trauma that I go to Toyota once a month now, and mainly work with the medical staff and sometimes with the ESI teams, early symptom investigation teams, and go over ergonomic problems and ergonomic designs with some of the engineers. But you're right, Peggy. The apprehension of re-injury is extremely high and a big part of the rehab process. And that's why we do a lot of work simulation before they go back into the work environment. And we'll get a lot of the same tools and the same activities that they're doing. But it is tough to change that mindset. And so one of the policies at Toyota is when they have an injured worker, they will send an ESI group out, and they will actually evaluate the workstation and see if they can identify risk factors as it relates to the injury that they had. And then they also do a lot of proactive surveillance and look at injury patterns. And say you've got, say, three lateral elbows in one zone, they'll actually take that data and go and say, okay, what are the activities that's occurring that will create a lateral elbow problem? And oftentimes they'll come back and ask us to kind of help them with what are the risk factors specifically for lateral elbow or for medial elbow. So they're very, very proactive because they look at injury as waste or muda, and they're very, very focused on that. Whereas I've been in other factories that are not quite as proactive, and they're not, and so they don't really have a good proactive solution. Oftentimes the workers are doing their own ergonomics with no training, and they're just kind of setting their station up how they want to. And then they wonder why they have these trip injuries, these back injuries, these slip injuries, these cuts, because they're just not set up right. So I've had the pleasure of going into a lot of different factories that support the automotive industry, and they're not. And it's sad that they're not. If they were all like Toyota, we would be out of business. But unfortunately, the majority of the people are not, and so therefore they suffer with just having a program in place, just having a
Yeah.
proactive program in place, just a basic set of skills to be able to identify. Well, that's what we did tonight. Just to go through and say, here's a series of pictures of a job. What do you see wrong with it? That they struggle with that, and they're looking for solutions. You know, that's one reason why I use the Reba and the Rulo a lot, because it's real simple. It's easy to use, easy to grade. It's very fast. It's not perfect, but it does give them a starting point. And there's so many now new. There's a lot of new ones out that are exciting. So I'm anxious to see as the Algo progresses into industry and construction. It's going to be interesting to see how that goes, because I think it's going to be really exciting. People need standardized solutions to help them solve
Yeah, amen to that.
problems.
Yeah.
Definitely. Thank you, Dr. Greg Pitts. That was amazing. And we know this video gets put on our YouTube channel and hundreds of people watch it. So whether it's in the next few weeks or months ahead, we'll be able to reach hundreds of people in our audience. And again, once again, thank you to our panelists. I'm going to go ahead and share my screen real fast.
Thank you so much. I appreciate it.
Yep, one sec. If want to go ahead, Steve.
Yeah, well, first thing I want to do is I want to thank, I want to thank Greg as well. We certainly appreciate you. You're a soldier, and it's like Dr. Berry said. We you tie these things in so well together, and that's really giving, and we're super grateful. And same thing with you, Dr. Berry. We appreciate your time and your expertise for sure. And this is I can't sing your praises loud enough. And Albert Moore, you show up every time. It's a great group, and I love the way these things are coming together. And I can't see Nicole. I'm assuming she's still on, but if you're still on, they let me sit in your chair till you got here tonight. So, but I appreciate your time as well and your expertise. So, yes, and we call them sponsors or whatever you want to call it, but these are friends of Ergonauts, and these are just some companies and some products that we like. We don't get paid for it, so but we really like them. Superfeet, an amazing product. I believe a lot of what we talked about tonight. If you start out with bad posture, with bad feet, you end up with the risk factors go out. And in my particular case, Superfeet, they changed my life. So home seating, it's a perfect seating system. It's one of the few things that'll show up at your door, and you could be sitting in it 10 minutes later. So they've done an amazing job, and they're a great chair. Commonwealth hand therapy, which would be Dr. Pitts's place of business, or his places of business. He's got a chain of hand therapy, physical therapy clinics that rock. So anyway, iHealth 360, one of our panelists who got off early, Lanisha Littleton. That is her new launch, and we're definitely supportive of that. She's doing some good things out in the Bay Area, and we look forward to working with her in the future. And our Atomic Ergo van has turned out to be a jewel, and we've got some great people with a lot of experience, and our main focus remains the same. We want to give people enough education if they want to jump in we need all the help we can get in the ergonomics business. So and everybody started somewhere, so we love those. And let me move this over to the other side here. So Pete Atomic Ergo, and then I want to mention Clem Consulting, which is Kirby Mask. He's one of our board members. He's doing some great things down in San Antonio. And if you've got some cool things going on, Kirby he's a great ergonomist. So that's really all I've got, Ray. And I did want to give you a big shout out. You show up every single time, and you put these things together, and they turn out great. I'm eternally grateful to you, and so. And oh, I get a shout out on the 14th day of December. We have one on casters. It's we're looking at it. We have a solutions series we're getting ready to do on mission control, and casters are definitely a solution, but they're a wheel's not a wheel, and you'll see what I'm talking about. But it's going to be a great great training, and we're going to be working with a great company to provide some good information. So that's all I've got.
Yep, everyone, please join us again on December 14th for our next mission control. And again, thank you everyone for joining us tonight. Everyone have
Thank
a good
you.
night.
Happy
Thank
Thanksgiving.
you.